Welcome. Today's FERNE educational opportunity discusses the Dizzy Emergency Department patient and the Grace 3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. What are the Grace 3 recommendations regarding the triggered episodic vestibular syndrome patient? So what is the Grace 3 recommendation regarding the use of the Dix-Hallpike test to diagnose PC-BPPV for triggered episodic vestibular syndrome vertigo patients? The Grace 3 guidelines state that using the Dix-Hallpike test to diagnose posterior canal BPPV is optimal. There's a moderate certainty of evidence in the published literature. It says, do the Dix-Hallpike to diagnose PC-BPPV. Let's consider this more at length. BPPV can only be diagnosed in patients with triggered episodic vertigo. This is important because patients with either acute vestibular syndrome or spontaneous episodic vestibular syndrome cannot be diagnosed with BPPV. AVS patients never have BPPV. We know that the Dix-Hallpike test can diagnose BPPV, and we know that there are other tests that help to distinguish HC-BPPV from PC-BPPV, knowing that the horizontal canal requires different testing than the Dix-Hallpike test. What is the Grace 3 recommendation regarding the use of CT or CTA for triggered episodic vestibular syndrome vertigo patients? The Grace 3 guidelines state, do not routinely use CT or CTA in these triggered episodic vestibular syndrome patients. There's a moderate certainty of evidence in the published literature that states do not do CT or CTA in these triggered episodic vestibular syndrome patients. Why is that? So we know that for patients with triggered episodic vertigo, there's no need to do a non-contrast head CT because it won't reveal the pathology causing this type of vertigo. We know that triggered episodic vestibular syndrome is not related to large vessel occlusion, such that CTA is not a useful test in these particular vertigo patients. What is the Grace 3 recommendation regarding the use of MRI or MRA when the Dix-Hallpike test diagnoses PC-BPPV in these triggered episodic vestibular syndrome vertigo patients? The recommendations state, for posterior canal BPPV diagnosed by a positive Dix-Hallpike test, do not routinely confirm by using an MRI or MRA. There's a moderate certainty of evidence in the published literature to support this recommendation that says, when you diagnose PC-BPPV, do not do an MRI or MRA. We note then that if the Dix-Hallpike test is positive, then the diagnosis is BPPV and no MR testing is indicated. This means that the triggered episodic vestibular syndrome is peripheral due to an ear semicircular canal problem and not a central etiology. We know that this BPPV is not always in the posterior canal. As a primary step, the clinician in the emergency setting needs to be able to do the Dix-Hallpike test and interpret the results of this test in order to diagnose PC-BPPV. So what are the GRACE 3 summary recommendations for triggered episodic vestibular syndrome vertigo patients? So in these triggered episodic vestibular syndrome patients, the Dix-Hallpike test can be used to diagnose posterior canal BPPV. If BPPV is diagnosed, there's no need to image these patients once you determine that the ability to reposition the semicircular canals suggests the diagnosis of BPPV. If a central diagnosis is considered, then it is important to consider MR-DWI testing to find a ischemic penumbra and a possible stroke lesion, or at least urgent referral so that this test can be done in a timely manner. In these triggered episodic vestibular syndrome patients, there's no need for CTA or CTP testing. What do the GRACE 3 guidelines say regarding the treatment of the dizzy or vertiginous patient with steroids? So what is the summary recommendation regarding steroid use for vertigo patients? Using shared decision-making with patients regarding short-term steroid treatment, the clinician can treat vestibular neuritis within the first 3 days of symptoms. Now, there's a very low certainty of evidence in the medical literature to support this, hence the need to discuss this treatment with the patients. But it suggests that the clinician should give steroids when feasible. So if a peripheral etiology is suspected for an acute vestibular syndrome patient, use steroids when indicated. But because of the low certainty of evidence, it is unclear when it is exactly to be used, and this needs to be considered by the clinician and discussed with the patient. So why is it shared decision making, and what are the issues to be discussed, and what could be a templated discussion recommendation by these experts? This information can and will be determined with more study of these GRACE 3 recommendations. And what is the GRACE 3 summary recommendation regarding use of the Epley maneuver for vertigo patients diagnosed with PC-BPPV? The Epley maneuver should be used for patients diagnosed with posterior canal BPPV. There is a strong certainty of evidence based on the medical literature that says do the Epley maneuver for patients with PC-BPPV. So we know that BPPV is only diagnosed in triggered episodic vestibular syndrome patients, and when the Dix-Hallpike test is positive, then the diagnosis is BPPV. Treat this BPPV with the Epley maneuver. In order for this sequence of events to occur, the clinician needs to be able to do the Dix-Hallpike test and the Epley maneuver. The question is, should the physician who does the Dix-Hallpike test and the Epley maneuver be the emergency clinician, or should it be a neurologist or physical therapy clinician in follow-up? Note, often the Epley maneuver must be repeated by the otoneurology physiatrist prior to success. And so it may not be feasible to begin this therapy in the emergency department prior to the use of medications and timely referral to an appropriate individual who can do both the Dix-Hallpike test and the Epley maneuver. For more information, email me at fern.org@gmail.com. You can go to our fern.org website or find us at fern.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.